Marco, thank you very much for the introduction, and it's a pleasure and a privilege on behalf of all my colleagues in the task force to present to you the recommendations regarding dual antiplatelet therapy type and duration in patients who receive oral anticoagulation. These are my disclosures. We saw already the great number of trials that are available and help us to choose the type and duration of dual antiplatelet therapy in patients with coronary artery disease over the course of the last 20 years. However, of all of these studies, we only have 3 smaller studies which give us meaningful data in relation to the management of patients who are receiving oral anticoagulation therapy. That's the WUST study, a modest-sized investigator-initiated trial comparing triple therapy at 12 months with the dual therapy of just clopidogrel and oral anticoagulation. The ISAR triple study, again, a modest-sized investigator-initiated trial comparing 6 weeks and 6 months of dual antiplatelet therapy in patients on oral anticoagulation. And the Pioneer AF, a somewhat larger but still relatively speaking modest-sized trial which compared oral anticoagulation with a NOAC in reduced dose as part of a dual therapy with a triple therapy with a very low dose of NOAC, and compared this with standard triple therapy with a vitamin K antagonist. Now, on the basis of this small number of trials, you can say that many of the recommendations for this part of the guideline are not as strong as as other areas of the guideline. In particular, we should make a judgment in general on case-by-case basis based on the unfavorable patient profile for a combination of oral anticoagulation and triple therapy. Factors which we will consider are short life expectancy, malignancy, poor expected adherence to therapy, a poor mental status, early end-stage advanced renal failure, advanced age, prior major bleeding or prior hemorrhagic stroke, chronic alcohol abuse, anemia, and clinically significant bleeding while on dual antithrombotic therapy. And these are factors which make the patients a priori unsuitable for a combination between dual antiplatelet therapy and oral anticoagulation. Now, we've summarized the recommendations in relation to dual antiplatelet therapy and oral anticoagulation in one table, which I will present to you on the following 2 slides. To reinforce what I said earlier, you can see that the general strength of recommendations and the strength of the evidence is lower compared with other areas of the guidelines. In fact, we have a single class 1 recommendation, and this is level of C evidence, and this is to state that it is recommended to administer peri-procedurally aspirin and clopidogrel in patients undergoing coronary stent implantation. So regardless of the strategy that you subsequently choose, be that a triple therapy or a dual therapy, then patients around the time of PCI should be treated with aspirin and clopidogrel. Now, as a general recommendations in patients treated with coronary stent implantation, triple therapy with aspirin, clopidogrel and OAC should be considered for 1 month, again, and in line with the general recommendations in the guideline, irrespective of the type of stent used. And this is a 2A recommendation, level of evidence B. Triple therapy with aspirin, clopidogrel and OAC for a longer duration, between 1 month and out to 6 months, should be considered in patients who have high ischemic risk, and this may be due to acute coronary syndrome or to other anatomic and procedural characteristics, which I will show you in more detail later, which are perceived to outweigh the bleeding risk. Again, this is a 2A recommendation, and the level of evidence is B. Finally, in terms of dual therapy with clopidogrel and oral anticoagulation, this should be considered as an alternative to 1 month triple antithrombotic therapy in patients in whom the bleeding risk outweighs the ischemic risk. And again, this is a 2A class of evidence, and the 2A recommendation, and the level of evidence is A. Moving on to look at the long-term treatment of patients, and particularly beyond 12 months. Beyond 12 months, discontinuation of antiplatelet treatment in patients treated with OAC should be considered with a 2A class of recommendation, level of evidence B. In patients who are treated with a vitamin K antagonist in combination with aspirin and or clopidogrel, the dose of intensity of vitamin K antagonist should be carefully regulated and kept within the lower range of the target INR, and with the aim of keeping the time in therapeutic range between 65 and 70%, a 2A recommendation, level of evidence B. When a non-vitamin K oral anticoagulation is used in combination with aspirin or clopidogrel, and I think this is an important point, there was a lot of discussion in the task force, the lowest approved dose effective for stroke prevention tested in the atrial fibrillation trials should be considered, and this is a 2A recommendation, and the level of evidence here is C. In the specific case of rivaroxaban, because this was examined specifically in the Pioneer AF study, when rivaroxaban is used in combination with aspirin or clopidogrel, rivaroxaban 15 milligrams may be used instead of rivaroxaban 20 milligrams once a day. This is a weak recommendation, 2B class of recommendation with a level of evidence B. Finally, in terms of a single red light, the use of ticagrelor or prasugrel is not recommended as part of a triple antithrombotic therapy in combination with aspirin and OAC, and this is a class 3 recommendation. This is an algorithm for dual antiplatelet therapy in patients with an indication for oral anticoagulation who are undergoing percutaneous coronary intervention. You can see that the risk should be adjudicated based on concerns about what prevails. Is it the ischemic risk which prevails, or is it the bleeding risk that prevails? In cases where the ischemic risk is felt to prevail, then triple therapy is recommended for a duration of 6 months, a class 2A/B recommendation with aspirin, clopidogrel, and oral anticoagulant. After this, a dual therapy with clopidogrel or aspirin alone in combination with oral anticoagulation is recommended out to 12 months. This is a 2AA recommendation. In patients where the concerns about bleeding risk prevail, then there are two options: either 1 month triple therapy consisting of aspirin, clopidogrel, and oral anticoagulation, a 2AB recommendation. After this 1 month time period, switching to a dual therapy, again aspirin or clopidogrel in combination with oral anticoagulation, a class 2AA recommendation, or dual therapy immediately after the PCI, up to 12 months, a combination of clopidogrel and oral anticoagulation, and a 2AA level of evidence. After 12 months, to re-emphasize, the recommendation, a 2A recommendation, is to persist with oral anticoagulation on its own and to discontinue antiplatelet agents. Here, just to re-emphasize, all patients undergoing PCI should be treated with aspirin, clopidogrel, and OAC. The patient then should be immediately stratified as ischemic risk prevailing or bleeding risk prevailing. The bleeding risk prevailing patients, either a short duration dual therapy or a short duration triple therapy or a dual therapy. Ischemic risk prevailing, then a triple therapy which continues out to 6 months, and long-term monotherapy with oral anticoagulation. What might be features that identify patients as high risk for stent-driven recurrent ischemic events? These were identified, and we've seen some of them already in earlier presentations. Prior stent thrombosis on adequate antiplatelet therapy, stenting of the last remaining patent coronary artery, diffuse multivessel disease, especially in patients with diabetes, chronic kidney disease with a creatinine clearance less than 60, at least 3 stents implanted, at least 3 lesions treated, a bifurcation stenting intervention where 2 stents are used, a total stented length of greater than 60 millimeters, and treatment of a chronically occluded vessel. In terms of assessment of bleeding risk and strategies to avoid bleeding complications in patients treated with OAC, it is recommended to assess the ischemic and bleeding risks using validated risk predictors such as the CHADS-VASC, the ABC and the HAS-BLED scores, with a focus on risk factors that are modifiable. There is a general recommendation, and this is repeated throughout the recommendations also from other professional societies, of course, to keep the triple therapy duration as short as possible and to consider dual therapy instead of triple therapy. NOACs may be considered instead of vitamin K antagonists when NOACs are not contraindicated. A target INR should be achieved in the lower end of the recommended range, and the lower dose, consider lower NOAC regimen tested in the approval studies, and apply other NOAC regimens based on drug-specific criteria for drug accumulation. Clopidogrel, again, is the P2Y12 inhibitor of choice. Aspirin should be administered in a low dose, and PPIs should be a routine part of care in these patients. I alluded briefly to comparison with other guidelines, and the comparison with the AHA-ACC focused update on dual antiplatelet therapy from 2016 I can mention briefly, because in this guideline, and we were happy to have some of the members in our task force, there was no specific provision for triple therapy. In fact, the text states that the recommended management of patients on triple therapy with aspirin, P2Y12 inhibitor and oral anticoagulation was felt to be beyond the scope of that focused update. Some general recommendations were made, again, mostly in line with our general recommendations regarding the assessment of ischemic and bleeding risk scores using validated risk predictors, with regard to keeping the duration of triple therapy as short as possible, and to considering dual therapy as an alternative, considering a target INR in the lower therapeutic range, for example 2 to 2.5 in patients with atrial fibrillation, clopidogrel as the P2Y12 inhibitor of choice, the use of low-dose aspirin, and here a less liberal recommendation for PPIs in patients with a history of gastrointestinal bleeding or those who are felt to be at high risk. A brief comparison is also warranted with the ESC guidelines in atrial fibrillation, and here the recommendations of the task force are broadly in keeping with the recommendations for atrial fibrillation. Again, you will notice no strong recommendations to recommendations throughout. In the ESC AFib guidelines in stable patients, there's a recommendation that 1 month triple therapy should be considered. That's a 2A. In patients with ACS who are felt to be, of course, higher ischemic risk, it's a 1 to 6 months duration, and again a 2A recommendation. And dual therapy, you can see, should be considered as an alternative, and at this stage this was a 2B recommendation. So finally then, the take-home messages with regard to DAPT therapy and a duration in patients receiving oral anticoagulation. It is recommended to treat all patients undergoing stent implantation with aspirin and clopidogrel at the time of PCI. Triple therapy duration should be kept as short as possible and should be 1 to 6 months irrespective of the type of the stent used. The choice of 1 to 6 months again is based on an assessment of whether concerns about ischemic risk prevail or concerns about bleeding risk prevail. Dual therapy with clopidogrel 75 milligrams per day in combination with oral anticoagulation should be considered as an alternative. When a NOAC is used, the lowest approved dose effective for stroke prevention tested in AFib trials should be considered, and discontinuation of antiplatelet treatment in patients treated with OAC should be considered at 12 months following the intervention. With that, I'll thank you for your attention and remind you that in addition to publication in the European Heart Journal, that of course all of these guidelines are available immediately as part of the ESC Pocket Guidelines, which is also available as an app. Thank you.
Thank you very much, Robert. That was an excellent overview of the field. Are there any comments, questions from the audience? So we have provided, okay,
Rob, excellent presentation. Jurt and Bear from the Netherlands. Don't you think that after Woest, Pioneer and just Redual, dual therapy should be the first choice? That's my first question. So in your guideline, it's still triple therapy first choice. My opinion is it should be dual therapy. That's my first question. The second question is you advise to use the lower dose of the NOAC. But after Redual, shouldn't it be full dose if you use it in double therapy? So that's my second question. The third question is if you use dual therapy, what's the role of ticagrelor?
Yeah, so we talked a lot about this in the task force with regard to recommendations for dual therapy or triple therapy. It was felt that on the balance overall of the evidence that we recommended triple therapy. Dual therapy is also a 2A recommendation, but the formulation I think in the text was a slight preference for triple therapy, perhaps a short duration of triple therapy of 1 month in patients in whom there was some concern about the bleeding risk. But this was definitely an area of considerable discussion. We are limited, and it bears re-emphasis, we are limited that we have a small number of trials available in order to guide us when we make these recommendations. We don't have any class 1 recommendations, and everything is class 2 recommendation. Why we didn't give more weight to dual therapy as an alternative is probably based on the overall quality of the evidence in terms of the size of patients enrolled in the studies, and I think that's why we felt both should receive a 2A recommendation. With regard to the dose of non-vitamin K oral anticoagulation here, also there was a lot of discussion throughout the task force. It was felt that the lowest dose shown to prevent stroke in the pivotal trials in patients with atrial fibrillation should be the dose that is preferred, acknowledging at the same time, of course, that there are many practitioners who will reduce the dosage of the NOAC below the dose which was studied in these pivotal studies. We specifically, of course, considered rivaroxaban. We didn't have, of course, information on Dual at this stage, so we considered rivaroxaban as a special case and said that you may consider use of 15 milligrams of rivaroxaban, which was not the dose studied in the pivotal trials for prevention of stroke, that you may consider this based on Pioneer AF. But again, this was a study that wasn't powered to give us confidence with relation to stroke prevention at the lower dose, and for this reason we chose a 2B level of recommendation. And finally, many of the studies have included a small proportion of patients with the more potent ADP receptor antagonists, such as ticagrelor, as you mentioned, and prasugrel, but it was felt that the observational data showing very significant rates of bleeding in patients who combine more potent ADP receptor antagonists with oral anticoagulation meant that for the moment we should give this a class 3 recommendation, and this was the only red light in the section on oral anticoagulation and dual antiplatelet therapy against combining with more potent ADP receptor antagonists.
Thank you, Robert. We have one question, then we have to move forward.
Nicolau Brazil. Just to make sure, for patients taking anticoagulant, there is no differentiation between ACS or non-ACS, that's correct?
So I think there's a slight difference compared to the atrial fibrillation guidelines from 2016, which I mentioned. We considered that when assessing the ischemic risk, that the presence of acute coronary syndrome at the time of stenting is one factor that can guide you to say that the ischemic risk prevails and you should recommend 6 months of triple therapy. It's not the only factor, but it's one factor which would guide you to 6 months, whereas stable patients in the absence of other high-risk factors such as complexity of disease or of interventional procedure may be selected to receive a 1-month duration of triple therapy. So in answer to your question, there is a distinction based on the presence or absence of acute coronary syndrome at baseline, but this is just one of many factors that flow into the algorithm when you choose between a 1-month and a 6-month duration of triple therapy.
Thank you.